Right, good evening, everybody, and welcome to our Meet the Medical Profession. Tonight is going to be a great night. We've got Dr. Una MacFayden coming to speak to us very shortly. But before she does, there's just a few things, obviously, I'd like to go through to introduce. First of all, obviously, thank you for joining us tonight and obviously spending the time to join us on this webinar. Una is going to be presenting shortly for about 20 minutes, and then we've got some questions which have been sent to us prior to tonight. But obviously, if anybody's got any messages then or any questions following that, please put them in the chat function, and then obviously we can put them to Una, and obviously we can go through them from there. I'd like to introduce Una to you all. Like I said, she's going to present for about 20 minutes. So, Una, thank you for giving up your time tonight and put this presentation together, and obviously going to go and answer all the questions. As always, we appreciate all the time any experts give to us so that obviously we can then obviously pick your brains and everything else. So if you want to screen share and I can make sure that it's working, it's up.
Excellent, thank you. First of all, thank you all very much for inviting me to join you. And just a warning that I will be asking for your help as much as giving you information, because I'm very much at the start of my journey back into learning about adult medicine. So I'll be sharing some of what I've learned and hoping that you'll be telling me some of your experiences too. So what I thought I would do just over this time is to outline quickly how I've come to where I am with TOFS and with looking at transition for young people from children's to adult services. And I think I'd said to Sarah when I started that I'm very fond of TOFS as a condition to look after, because it's been something that I've always had patients working with me who have been very special people. So I shall tell you a bit more about how things have been. For my own journey, when I was an undergraduate and we were going through specialty training, I realised that I wanted to be a paediatrician. When I got to paediatrics out of all the specialties, and it was like being on holiday because the patients were just the best patients ever. So I learned about adult medicine through the specialties at that time. But then after doing my junior house officer in Edinburgh, I went on to postgraduate. I did 2 years as a residency programme in the Sick Children's in Toronto, which covered everything apart from hands-on surgery. We had surgical patients, but we didn't actually, we weren't attached to the surgical teams. But we had a very active neonatal unit, which now seems terribly antiquated because it was very much babies only, not parents, but they certainly had very skilled specialists working there. And I came back and worked as an SHO in Oxford, which was a medical neonatal unit, where I had lots and lots of practice about assessing babies, including resuscitation, and very forceful breastfeeding advisor. So I learned quite a lot about baby feeding as well. I then went on to Bristol, and that's really where I started the post-surgical babies, where there was Helen Noblet was our paediatric surgeon. She was a very assertive Australian lady, and she taught me a lot about looking after surgical infants. And I still remember one of those ringing in my ears. She had done an esophageal atresia repair, and her parting comment when she was going home to me was, "I don't want that tube to come out." And I, as a very junior registrar, was thinking, well, I don't really want it to come out either. But she didn't tell me how to make sure it stayed in. But that was my introduction to the importance of the nasogastric tube staying in place for babies who have their esophagus repaired. And all of you will know a lot more about what can happen if things go wrong with that repair. So I did my time in Bristol, and then I went up to Edinburgh again and did research, which was a combination of sleep research for clot death research and studies. Involved a lot of overnight recording of babies breathing, but also let me learn a lot about breathing patterns in babies, and that led on to my keeping a respiratory interest. which I took with me when I went to Leicester, where I was senior registrar and then a consultant. And in Leicester, I was really fortunate in a way that I didn't realise at the time, but our neonatal unit was combined medical and surgical, and we followed the patients through into intensive care, which at that time was a mixed adult and children's intensive care unit if the children needed that as they got older. And that's where several of the children with esophageal atresia repairs that I knew spent quite a lot of time. So I was fortunate in being able, as the medical senior registrar, to be responsible for surgical patients. And I think that was a really good way of seeing the need for joint medical surgical input to patients who have esophageal atresia and TOFS repairs. And I went on from being senior reg to being consultant in that same unit. And when I was consultant, I had my own clinic. So I had respiratory clinics, and we were able in that time to, taking forward the research I'd done before, to look at the respiratory patterns of babies who had had an esophageal atresia repair, and particularly to identify some of the respiratory differences in their patterns of breathing. And that was useful when we saw some of the younger children who had complications, respiratory complications, associated with the tracheomalacia that went with their Tracheo-Oesophageal Fistula. And it also let me have a feeding problems clinic, which was often very relevant for the children who had had tube feeding for a long time, and sometimes were quite aversive to having oral feeding. And that may be something that some of you have had experience of. After some time in Leicester, I moved back up to Scotland, and I worked in Forth Valley, which is Stirling area. And there I've been in a DGH hospital, which was my first experience away from specialist centres. And increasingly, I'm seeing the impact of the specialists being in a different area from the place where patients live. And I'm hoping that that's something that we might talk about in relation to the transition from children's to adult services. And then eventually, when I retired, I became a clinical lead for a network called Children with Exceptional Healthcare Needs at SEN, which I'll say more about. And that's brought me into a lot of work looking at the transition from children's to adult services. The Plus Forth Valley is a charity that supports families with a child who has disabilities so that they can enjoy leisure activities out of school, just as much as the children who don't have any disability. And IFIC is the International Foundation for Integrated Care, which is an organisation that looks at linking social care and medical care, and that's international, as it says. So that's the background to where I've got to where I am now. And the ways that I want to think about where transition fits into that is really what I learned when I was working as a paediatrician, but also taking on the clinical lead for the SEN network led me to look a lot more at the needs of young children and young people and their families when they're juggling a number of specialist medical services through childhood, and then as tonight's topic leads us on into transition into adulthood. The SEN network is one where the main criteria are around a child who has either tube feeding or IV feeding and other significant disabilities. And that always extends into having what we call comorbidities. That's other medical, physical conditions, as well as the developmental disabilities that are listed there. Or the child is dependent on some kind of ventilatory support, either ventilator or CPAP or BiPAP, and that this is a long-term requirement. So we have the at any time that a combination is present. But because there are some babies who can be predicted to have those difficulties before they're at an age to be assessed for learning difficulties, communication, motor skills. We have the age from birth onwards, if it can be known that they're going to have long-term needs in the future. Some of the babies and children in the SEN network, which is set up to ensure that the families across the whole of Scotland have access to the specialist care they need. Some of those babies and children may have quite limited life expectation, but others will go on into adulthood. More and more are surviving longer and longer because of advances in medical care. And this is where the challenge of ensuring that there is an adult service prepared for their needs has become quite a challenge to the SEN network. Within SEN, we have a number of activities, including e-learning resources and care pathways. And one of the care pathways that we identified was transition. And this is where I had my first light bulb moment, because as a doctor, I was looking after teenagers who were approaching transition from children's healthcare to adult healthcare. And so I was quite used to talking about transition. I'd been involved in a working group in one of the colleges looking at what we called Think Transition, which looked at specific conditions, including cystic fibrosis, which was an area that I did a lot of work in. And we thought we knew all about transition. I discovered when I was working with SEN that there were other people talking about transition in a completely different way. And Duncan will understand this, because I discovered that the families were being told that transition was something moving through education. And in Scotland, we have a project called Compass, which is designed to have a person-led approach to transition into adulthood through education. And so as a medic, I had to relearn what other people were talking about when they talked about transition, and then trying to join up the various professional groups so that the family could have some understanding of what we were all talking about. And Compass has an approach, and all of you are welcome to look at or even use Compass if you wanted to do so. We'll put the links in later. It has the young person who has additional needs of any kind. Many of the young people in that organisation have been those with neurodiversity issues, but will encompass those with physical health conditions as well. So they have the young person's area, the parent or carers area, and the professionals area. And my concern was that it seemed that the Compass team in this Association for Real Change were assuming that healthcare had coordination worked out. Unfortunately, I don't think that's always the case. And so we've had a lot of discussions and meetings and learning together in ways which I hope eventually will be supportive of families, but it is very much work in progress. There are a number of other approaches to transition planning. One of them is the Alder Hay programme, which is the 10 Steps to a Good Transition, which is a health transition programme. And these are all very uni-professional, if you like. They're all about healthcare. They may or may not have as significant an education input as the Compass, but I'm hoping that we can discuss some of that later on. In the course of working on these transition groups, I have been learning a lot about what's known and what's been researched about the adolescent brain. And this is something which I think comes into the questions that were submitted about how do we help young people to understand and be involved in their own transition. And a lot of the challenges that everyone has encountered over that period seems now to be related to some of the changes that are happening in the brains of adolescents. And the adolescent brain is an area that now has an increasing amount of research going into it. And I think at least lets us understand where some of the challenges come from. It does not, unfortunately, give us all the answers how to cope with those challenges, but I think that there are some consistent elements of working with adolescents that can be helpful when we're negotiating transition. The things that we're learning are about the major changes that happen in the brains of young people from about the age of 11 all the way through into their mid-20s. So it's taking us from children in early senior school all the way through to college, university, and into employment at a time when their brains are still changing. And over that time, their responses to what's happening to them, what's going on inside them, what other people are giving them to work on, is going to vary in a way which I think adults find difficult to comprehend. The young people do too. But at least if we understand, we can begin to work with the youngsters rather than seeming to be working at cross purposes. So all that we're doing around transition is happening with input from young people whose brains are changing. And I think they would certainly say that we don't understand them quite often. I think it's not surprising when we're dealing with people who are changing very fundamentally over that period of time. And the positives that are there about the way that young people are gaining skills that they do not have as children have to be balanced against the negatives of things that they find more difficult because they are adolescents. A very simple one within that is their need for sleep, that the adolescent brain goes along with needing a greater amount of sleep. And there's actually some changes in the time clocks that that adolescents work to, where they have a need to sleep, perhaps go to bed later and get up later in the morning. And some of the schools have taken this on board and changed their start times. But it's just an indication that the biological changes that they're experiencing impact on all areas of their life. So one of the things which I learned from working with young people, what I've been doing recently is talking to groups of young people about what they feel we should know about their experiences. And one of the things which I realised is that as a health professional, as a doctor, my priority was this young person's health, but it wasn't necessarily the young person's priority. And so if their priority, because their brain is changing, their prefrontal cortex is developing, one of the things that their body is making them feel they have a priority to get right is making social relationships. And Duncan and I were talking about the impact of lockdown and COVID on some of this, on the current group of adolescents. But just going back to our health transition, if the young person is desperate to be with their friends, it's not necessarily because they don't care about health, but just that their priority right now is not the same priority as mine as a doctor. And it might not be the same priority as their parents. And so one of the things which we're learning is that we sometimes have to negotiate understanding that we're coming from different starting points and aiming for different outcomes. So the brain development issue is a big one, and one that I think knowing it's happening can a little bit help with getting through it without necessarily having a way to bypass what's happening to their brains. We can at least understand that they're coping with a lot of things that maybe we don't as adults have in the same way. So the prefrontal cortex impact has all the things that people describe in adolescence, where they can be very impulsive, that they may struggle to set priorities in the way that adults think they should. They may make plans and then change them. They may find it difficult to make decisions and make decisions that perhaps are not as safe or as sensible as an adult might think. And they may have difficulty difficulty in foreseeing the consequences of their actions. And that last one has particular relevance for making decisions around healthcare and consenting or dissenting from advice about necessary treatments or recommended treatments, which I'll mention again in a moment. The risk-taking or sensation-seeking is identified as part of what's going on in the brain. When that applies to somebody who may have vulnerabilities due to their health condition, then the issue about making decisions and knowing consequences becomes all the more important. So being aware that there are likely to be more impulsive, maybe not be quite so good at picking up cues from other people, taking risks, but knowing that they need to be helped to think about the consequences of their actions and their decisions, and where behaviours that may be fun for people who don't have a health condition may not be so much fun for those who do. When I was talking about the health transition, there are a number of guidelines to support the transition process. And one of the things that we're encouraged to remember is that the process takes years. It is not something that happens overnight, although I still do sometimes hear families saying that their child's discharge from paediatrics and move to another clinic in adults seem to come as a complete surprise on a kind of, this will be your last clinic, here's where to go next. And that should never happen because it doesn't help anyone. So knowing that there are guidelines and places to go for help, one of them is what's called the Ready, Steady, Go guideline, which gives the young person time to understand what's planned for the future, how to be prepared for it, and eventually how to feel confident in a new setting. So the Ready is, I think next slide goes into it, Ready starts in paediatric care from whatever age is felt to be appropriate by the young person and their healthcare team. Now that can be controversial, but it's a time when the young person can be encouraged to understand their diagnosis, know about their medications, why things are done, what's done, and beginning to be more confident in taking ownership, what we call self-efficacy. That moves on to being able to speak up for themselves in the clinic, not depending on parents to have all the answers, beginning to understand about clinic appointments. And one of the questions that we had submitted was about when they don't want to go to appointments. And this goes back to that understanding consequences, beginning to let them see that although they may have choices, they also need to understand what those choices may result in if it is moving away from the system that's trying to offer them help. Knowing about their medications, being able to order prescriptions and knowing why they need to make sure that those are in place, all of that can be practiced over that period called getting steady. And then the going ahead into the adult setting would be meeting with the adult specialists and beginning to actually attend clinics independently and being confident about being able to have a dialogue with their healthcare team. What I found working with the SEND network was that if you have more than one condition, trying to make your way through 4, 5, 6 Ready, Steady, Go guidelines all at slightly different times could be just almost too much of a challenge. And so where I've come to with all of this is the need for what we're calling co-production, actually working together with the people who know what it's like to have the condition, people who have cared for those young people all through their childhood, and understanding what's involved in becoming an adult and then becoming an adult with a health condition, and how parents and carers can learn how to let go of that responsibility for a young person's health care and working together to get the best outcomes. It is over and over again something that needs us all to learn about how to listen to each other, and that's from young person, from parents and carers, and from professionals, so that we're all listening to each other in a way that is genuinely trying to understand each other and not having our own agenda when we go in to listen, which I think many professionals struggle to learn. So we've all got to be a little bit humble about that. But it really, really makes a huge difference when working with adolescents, because many of them do feel that we are listening only to respond, and that gets their backs up. I have certainly learned that valuing lived experience is just invaluable, that we have an experts by experience group in our network, and without them we couldn't do the work that we've been trying to do. And so we genuinely share the learning. And I think TOFS can hold its banner high by saying that you have done that kind of shared learning from experience, really because you had to over the years, to actually look at what it means to be living with a repaired esophageal atresia and where we need to be focusing our needs and care. One of the things which is involved in that is really being able and ready to speak up for yourself or for the person you care for. In England, the NHS is emphasising the Ask 3 questions, and in Scotland, realistic medicine is the thing that is being promoted. Basically, they're both saying the same. They're both saying that we need everyone to understand what's going on with their condition, what information there is, what questions are important to ask, and what their choices are. And if you think back to what I was saying about the adolescent brain, that's happening to somebody whose brain is changing and developing over that adolescent period. So finally, I think our challenges, and we really do need to share them for TOFS and other rare conditions, because rare conditions are now being talked about in a way that they never have before. And I think there's a lot of opportunity for us to get things better. I think that one of the things we've learned is for adolescents and young people going through transition, for letting them help each other can be a very effective way of improving the transition process. And I put a few names there, which I'll fill in more detail if it's wanted, of groups that are focusing on that approach. And then that, what I said before, the co-production of resources that can be helpful. And what I would love to feel we can look to is having a UK and even international network of specialists who are identified as having the skills and the extra expertise and the research interest that will make things better over the long term. So thank you all. I hope we can be a joined up team, and I'd love to hear your questions and your comments. Thank you. Just stop sharing. Over to you, Duncan.
Thank you for that, Una. That was great. And I love the quote. You may be an expert in stroke, doctor, but you're not an expert in my stroke. I think that's a great quote.
That was a public meeting I went to, and it was an old man in the audience, and I just thought he was brilliant. I could just picture him.
That's a great quote. Might actually use that at school as well. Right, so if we start with the questions that we've been submitted first, and then obviously if people have got further questions in the chat, obviously we can look at those afterwards, and if people want to ask them, we can also bring some people online perhaps. So the questions that we have submitted, because we didn't have too many. So first one, what happens when they transition and don't consent and refuse to do appointments, treatments, etc.? So I presume this is like about TOF teenager who just doesn't want to do anything to know about TOF. Really. Yep.
I think this is where we started with that Think Transition project that we had, because all the chronic diseases, if you like, the teams that were working with them were all sharing the same experience. And we looked at how we might be able to improve things. And basically, the first thing was start early, to give the young person the feeling that they own their condition, that it's not being done to them. And really that goes right back to much earlier than adolescence, really into earlier childhood, to give them the confidence that I guess they are important, that this is part of them. And it's interesting, I was listening to two young women with cerebral palsy talking about how they came to understand their condition in adulthood and looked back on childhood. And part of it was that feeling that they were the centre of this condition. So I think the first thing is to let the young person feel that they own the condition, that they're not having things done to them. I think what I was saying about the adolescent brain, understanding that there are things going on in their brain that are different from what's going on in an adult brain, and not trying to equate what we as the adults feel to what the young person is feeling. And that's what this listening to understand is all about. It's actually saying, well, what are you experiencing? And really listening to that. Now, it may be difficult to understand what they tell us, but if we're not listening to try to understand, then we're going to be on a hiding to nothing. I think one of the practical things is to share with the healthcare team if you're having difficulties, not to say that they will have all the answers, but they may be able to help you. I've certainly seen a patient in the car park because he wouldn't get out of the car, and his mother wouldn't believe that I would go down to the car park. Well, it's no big deal for me, but between them, there was just a conflict that he was showing that he had some autonomy, and the mum was feeling that it was her responsibility to get him into the clinic. And so sometimes knowing that there can be some flexibility can help. And quite often that shocks the young person, I found. So they kind of throws them back when you say, well, okay, I'll just see you here then. And then it's kind of, oh, that wasn't meant to happen. So a little bit of shared understanding, shared experience. The consent thing, I think, again, that's starting early about letting them understand your point of view as the parent, that if they are at a younger age, say at age 11, then your parental responsibility comes into the decision making. And it is slightly different between the legal systems in Scotland and England, but there is a need for the child, the young person, to understand why you have that responsibility and why you will be involved in the consent giving. The older they are, the more they need to understand the consequences of their decisions. And that includes making a consent decision. And so giving them the 3 questions or the realistic medicine approach to say, here's what you should have a right to understand about what your doctors or your nurses are recommending for you. And that includes what will be the consequences if you do or don't agree to that decision. And so a little bit it's challenging their negativity. A lot of the negativity is often about feeling that they're being done to, that things are being done to them when they don't have a voice. And so it again loops back to that, listening to understand. If the decision they're making is going to threaten their life, then the decision from the healthcare point of view would be that they are not mentally capable of making the decision. And so the decision is made for them. And that's a big step. We don't threaten anyone with that at the start because very, very rarely is it needed. It's when mental health has become part of the issue. When physical health is the issue, giving time, listening, and feeding back and giving some ownership, I think, is a good start. And it may surprise you sometimes what makes the difference can be a very small thing. But the fact that you've listened enough to spot that and be able to respond to it can make an enormous difference. Again, I remember one boy who wouldn't eat. He wanted to have the takeaway down the road. He was a boy with cystic fibrosis. And the challenge was that he was meant to be in school and he wouldn't eat in school. And so I negotiated that he could be allowed to go out to the takeaway. So that was the first thing. We were pals. And then he came back to the next clinic and said, could he take his pal with him when he went out? Yeah, okay. So boundaries came into it then. But a little bit of it is just that, being an ally rather than being the boss. That helps.
It does help. Okay, so next question. Leaving the familiar or unfamiliar is often tricky. So got that part of that transition. What are the urgent things to know about when navigating care in an adult clinic?
I think knowing who's in that adult clinic, knowing how that system works before you actually get there, it's something which I'm hoping we're going to do a little pilot thing in my own hospital, or what was my own hospital, looking at a kind of, I don't know if any of you have been a pre-admission, coming into a children's ward and having a visit before it actually happens, so that children are familiarised with the environment and what's going to happen to them. And I discovered, shock horror, that nobody does that in the adult side. You're just told, come in for admission on a day. And so I thought, well, that's not fair if you don't know what you're coming to. So I would say in answer to the question is go and have a recce before you actually have to go there, if you can. I think one of the few positives out of COVID was to ask if you can have any remote consultations. So if it's something that doesn't actually need you to be there in person, especially if you're having to go to different centres for different specialists, then knowing what are the options once you've actually met the people involved, will you be able to look at having some choices there? I was thinking about this earlier today. Sometimes the most senior member of the healthcare team may be slightly less flexible than other members. And so it may be worth just finding out who you should talk to about what you feel are the important issues coming into a new clinic. In an ideal world, you might have gone through that guideline process where you've actually had a joint clinic with some of the adult team before the young person moves to the adult service completely. If there has been that opportunity, then hopefully you've got more idea of what's coming and who's involved. If you haven't had that opportunity, then I think giving them the unit phone call and just talking to the specialist nurse or the coordinator and just asking them, what do I need to know before I come to your clinic? I mean, quite often I think people are hesitant to ask for information and they think that's not available, but very often it can make a huge difference. So finding out as much as you can before you leave the familiar surroundings, I think is worth doing.
Okay, thank you. Yeah, it is scary going into adulthood. Having a daughter that's gone through it about 8 years ago now. You suddenly leave that a security blanket, I think in one essence I would call it, where you know all the doctors, you've seen them for the last 16 years, you know all of them, you know where everything is, you know what they're going to do. Suddenly just to go, okay, off you go. And sometimes they give you they say they're going to do this beautiful transition plan. And then we hear, people saying, no, they were going to do a scope, they were going to do this, they were going to refer us, they were going to tell us where we're going. And then all of a sudden, nothing happens. It's a scary world at times.
Actually, I'd love to know if TOFS would like to comment on this. Is something new. One of the kids that I was talking to was, well, all the families actually, but this one person was saying how awful it was to have to repeat the same information over and over and over again with every new person they met. And what are called passports, hospital passports that I've seen, are often quite lengthy. And I know from being there in an acute setting, they won't be read. And so I am trying to design a one-page summary of the key information that this person wants the healthcare people to know about, which is not all of their case notes, which can be huge, but just the things that are the priority for them. I'd love Top to tell me if I'm doing something useful because it's just what's in my head.
we're actually in the process of actually designing our own,
Yeah.
going through that process. So if you want to at some point get in touch with the
Yeah.
office,
Yeah.
they can obviously they can put you in touch with either Kate or anybody,
Right.
all the others who are partly designing it, and obviously we can look at that. And I know our ARM and Max's Trust are also doing the same as well. So it's worth, getting in touch with the office and we'll pass on your details. And
Right.
then obviously you're not starting from scratch, certainly for us.
Brilliant.
But yeah, it's very useful because you do find every time you go meet a new person, you've got to explain everything all over again, right from the word go. Okay, tell me about your history. Well, so yeah, absolutely. Right, next question. How do I ensure my team is changing medical department smoothly in understanding his condition?
I think again, it's that thing about starting early, that you build up on what the condition is. People talk about health literacy, and I think having the courage to question things, that if it doesn't make sense or new words are being used, to be willing to say, I don't understand that, and not to think that that means that you're stupid or you haven't been listening, but just to say the fact, I don't understand. And so I think the more that you can encourage your team to feel confident to do that without it being seen as a challenge and not to be feeling inferior about it. I think medics very, very much underestimate the amount of jargon that they use. They don't know they're doing it because they've been using that language for years. And so what to them is, I've heard this thing about easy read. I think everything should be easy read, because if you can do it easy read, why make it difficult? So one of my favorite questions is to say, excuse me, can we all have easy read? But then even the easy read has jargon in it. So I think that the implication that easy read should make sense to everybody is wrong. I think easy read is better than non-easy read, but it's still got information and words that should be questioned. So in terms of making it smooth, I think being confident enough to understand the condition, and most of the kids are experts in this, but actually to work through more than just the superficial part of it, to be able to say, well, I've got Tracheo-Oesophageal Fistula. That sounds great, but actually, do you know what that means? Do you know what it is inside you that is what a fistula meant? Do you know what your surgery has been and why you had it and why it's been the right thing for you? These kind of things can all be done in small little chunks over time, so that by the time they get to the adult side, they are confident. I think sometimes to understand that they are, and you are, much more expert in this condition than the health professional that you're meeting. And the health professional will be feeling very unconfident if they haven't seen a lot of people who've had a TOF repair. So that sharing and trusting the person, I think, is part of having a smoother transition. To actually be open about it. If the person hasn't been used to seeing people with TOFs, to be willing to encourage them to learn more about it without putting them down, but just being able to share what's special about you and your TOF, like the stroke, to say, okay, you've probably heard about TOFs in your medical training. This is how it's affected me. And that actually is much more easy to live with than I'll tell you all about TOFs, doctor, because that implies that a doctor doesn't know what he should. So it's a little bit of negotiation skills and that co-production to say, I've had hopefully, a good experience through childhood. These are the things that are not giving me any problem, but these are the ones that I want you to know about because I'm a bit concerned about them. That very commonly is to do with reflux or eating problems, but might be to do with respiratory. I think one of the things that I've been looking out for and haven't seen much about is difficulty with coughing when you've got something like COVID, to actually clear your airways when a bit of your airway isn't quite as efficient as it should be. And so these kind of things where if you are having difficulty, to be upfront about telling someone, and then you share the decisions about how to look into it, how to treat it, what's going to happen next. Does that make sense?
Yeah, it does. Makes perfect sense. That's really good. So, I mean, obviously we talk about TOFS or OA-TOF now as being a lifelong condition, and obviously certainly recommending for our members, to be getting possibly even a scope every sort of like 3 to 5 years, just to double check that everything is still working the way it goes. Which sort of takes us on to the next question. From research, is there a trajectory of the age, of ages where checks should happen and how often? And are there some symptoms part of that lifelong passage going through?
As far as I can tell, there are no fixed rules. And I think, again, this is where that co-production thing comes in. I think to have a discussion around, given that there isn't a set thing that you must have this every 3 years or else, but to say that 3 years is very often a time to update how things are because your body system changes over time. But also, I think, to draw into that the mental health and well-being bit about what's worrying you. And so if you're worried about your symptoms, then to try and look at what would reassure you. So it might be that the evidence at the moment says that 5 years is probably enough between scopes. But if you're worried at 3 years, that's important, that if you can be reassured at 3 years that everything's fine, then you save 2 years of worry and anxiety. So I think there isn't a set number of years between scopes. There might even be some people who are so distressed by having a scope that they want to leave it until there's clearly a new problem. That's what that co-production means. It means having a discussion, knowing that for you, this is the right decision, not that there's a checklist that you have to fit into. And that's maybe taking that adolescent brain into adulthood and saying we all have a little bit of that. It's about me and what I'm experiencing rather than what's the rule book.
Okay, that's great. That brings us to the end of our questions now, Una. But before we disappear, I'd like to introduce Kate, who's just come onto our screen now. I think you'll see Kate come on. And obviously, Kate is one of our trustees and obviously an adult TOF as well, and an ex-nurse, and lots of other things, and working through loads of stuff for us as part of TOF. So, Kate, do you want to just talk about the passport for a minute?
Yeah, I can talk about the passport briefly. We're a working group across adults and parents, looking at the key points that would be of value. And as you've already said, Una, really needs to be condensed. I mean, obviously, you're a medic. I was a nurse, and when people come with loads of information, busy staff haven't got time. But the ones who can give you a really concise overview, without being as you said, behaving as if they're the ones with all the medical knowledge. It's a really delicate dance, isn't it? So that some medics don't take offence at all. I mean, I have a superb GP, but I've certainly been in front of professionals who, you just are ignoring me because they don't want to hear it from a layperson, even though we have the lived experience. So it is a delicate dance. But yeah, we are working on that. Caroline Love is leading that. Caroline Love, who I think she wrote to you on behalf of the adult working group in relation to some of the non-transition issues that most of the adults have faced. But yeah, so that's very much a work in progress. And certainly with Max's Trust, I'm working, volunteering with them. They represent families with infants born with anal rectal malformation, urogenital issues. And they're a relatively new charity in comparison to TOFS. In fact, they're a very new charity. But they have got, I think it's, Kat Ford, I think she's a Bart's paediatrician, and Joe Curry, who's taken an interest in developing a health passport with Max's Trust. Yeah, so these things are they're happening out there.
Brilliant. That's great.
Yeah.
I think that's
and if you can throw in any influence, that would be fantastic as well. Support us on this journey, because we're all learning, and to get it right, the last thing we need is people having too much information, and as you say, medics just haven't got time for that and just putting it on one side. So
I think that I think just to be practical about it and say what will people use rather than trying to be perfectionist, because then you end up with 6 pages and they're just not read. So I'd be very keen on that. I know your leaflet for GPs is appropriate for GPs, but like you say, Kate, once you're in an emergency department, nobody's going to read it. So it needs to be a 1-pager and then they can go on to page 2, 3, 4, 5 when the emergency is under control.
Yeah. I'm just following on from your discussion, really. I was just I'm looking at my notes. I have to look at my notes because I was scribbling. I'm in my late 60s now. I'm born with TOFS and ARM and other anomalies.
Well done.
And it's so, pardon?
Just well done. Just so pleased.
I'm still here. I'm breathing. But I think some of the things that you said are so important. They're desperately important. They're still not happening, but they are happening more. And owning your condition is so important. And I look back and I see it with my adult colleagues as well, the ones that were born with TOFS or ARM or VACTERL. Even now they're learning about their condition. They were not given that information. I found that information for myself. That's partly being a nurse and partly being a bit of a Jack Russell Terrier, whatever. But having that knowledge is empowerment.
Yes,
and being given the skills as a child, that needs to start in very early years, and I absolutely agree with you. Because then you can put it across in a very delicate way. So you're not imposing, you're not criticizing, but you can engage with professionals so that they understand the lived experience. Absolutely. I also think that many of our anomalies are hidden. So until we cough or until we have a sticky, people can't see that. We don't go around displaying our scars. It's not like some anomalies where you can very obvious, maybe a limb anomaly or a facial disfigurement or something. But our anomalies are hidden, and we have the scars to show them, but people don't see that. So I think that makes it sometimes a little bit more difficult, because people can look and think there's nothing wrong with you, so why do you have to go to the hospital, or why do you have to have time from work, or why do you struggle with particular aspects of your employment, or that kind of thing. And just going back very quickly, I'm sorry if I'm holding the floor, but the other thing, when you're a child, but there are many, as you know, rare and complex anomalies, conditions that affect children, and it's about making that more the discussion around that in school. That there may be a child with diabetes or CF or asthma or a mild cerebral. There might be in your class that you're not even aware of, that they're going to appointments, they're having hospital school, they've got scars. But it's almost like this. It was taboo for years, and that's what it's about: taking those sticky plasters off and saying, there are other children, and if we become a society that we can share that, then children don't feel alone. And I get very emotional about this, but feeling different, feeling alone is really scary, and that makes you cross. It makes you frustrated. It makes you kick back at professionals. It makes you kick back at parents. And when you're adolescents, I think you can then engage in risky behaviors, because those are the things you control. Yes. You don't control all of this medical stuff. You don't control where your future's going. You don't understand what's happened to your body and why you've got those scars. So you do something that's way out there.
That's back to that ownership, isn't it? And feeling this is me. And that's exactly what the young women with cerebral palsy were saying, that they realised that they owned their disability. And they were actually saying that, looking back, they almost wished that people hadn't tried to normalise them and tried to make them fit into school activities, because they were never going to be able to do that in the same way as other children. And as they became adult, they realised that they were just rather special, and it turned it round into something.
I think as well, for many of us, whether it's a TOFS or an ARM, we were told we were fixed at surgery. fixed, you know, and I can understand that surgeons have done an incredible job, and they feel that their work is done, and they've got you through those early days of early hours of life even. But in fact, we have many complications, we have many things, many health challenges, and
I think that's one of the things which is going to be a challenge for me, if I could move on, is to get adult surgeons to understand about what their pediatric colleagues have fixed. Because sometimes that's something that they've never really encountered. I found that with a boy who had Hirschsprung's disease and had a chronic pull-through, and he was just not understood in the adult side because he's just had a condition that wasn't often seen. So I think, again, that's back to that co-production, to actually share the expertise, and the patients are the experts. They know more than anyone about it, and particularly long-term outcomes. I mean, what you're saying about the long-term, medical research is not good on long-term outcomes. That's going to be best done by the people who live it and really respecting that expertise, because that's the only way we're going to learn. So well done, TOFS. I was involved with the TOF child book, and then when I saw the TOF adult book come out, I thought, yes.
Yes. And we're now working alongside our other organisations, because it's becoming more apparent, I think, that there are adults out there who were not diagnosed with some of the other aspects of VACTERL. You know, I was talking to a couple of people just recently with TOFS, but they've had problems with their lower back, and they've got renal problems, you know, and they've got horseshoe kidneys, and they never knew they were born with. So the investigations, at least for infants and young children now, the investigations are done, the MRIs, the CTs, you know, renal function testing, etc. They're all part of the sort of care that they should be automatically receiving, but there is this cohort of adults that perhaps kind of miss the boat. So it isn't until they pitch chronic back pain, lower back pain, and finding they've got vertebral anomalies, you know, missing hemivertebra and occulta, spinobifidal occulta, and
oh wow. So I think the rare conditions collaboratives are going to be an important area for people to just share some of the things that need to be known about. Definitely.
I think it's time for me to say thank you, Una, for giving up your time tonight. It's been absolutely fascinating listening to you talking and obviously answering the questions. Kate, for joining us for the last few minutes, sharing your wealth of knowledge as well. So please, like I said at the beginning, fill in the Q&A response survey form, please. That will be great. Don't forget to like us on YouTube. And obviously, if you've got some history, you want to share some stuff with us, with the office, about your experiences of transition, whether it was just a few years ago, whether it was 20 years ago or 30 years ago, you know, we'd love to hear from you. And then obviously we can then keep that on record, and then we can obviously share it and put it into for good use. So thank you for your time. Like I say, again, Una, thank you for giving up your time, and have a good evening. And I'll hopefully see you again soon for another Q&A. Thank you.